Everyone. I welcome you all on behalf of our team of the Cutting Edge webinar. So, we have successfully been having these webinar series since last month, and we are thrilled to have Jalandhar and Amritsar Society with us this time. I would like to introduce our team, Dr. Meenu Agarwal ma'am, who is the President POGS, Dr. Vaishali Chavan ma'am, who is the General Secretary POGS, and Dr. Charulata Vape ma'am, who is the Clinical Secretary of POGS. I would request Vaishali ma'am to introduce our guests.
Thank you, Madhura. A very warm welcome to everyone for this cutting edge webinars by POGS. This is an endeavor by Pune Obstetric Gynec Society to spread knowledge. And these are every weekly, every Tuesday webinars called Cutting Edge Webinars, brainchild of President Dr. Meenu Agarwal. I would like to welcome for today's webinar for inauguration Dr. Alpesh Gandhi, President FOGSI, Dr. Ragini Agarwal, past Vice President FOGSI. Alpesh sir was also past President FOGSI, and Dr. Asha Bakshi, past Vice President FOGSI. And can we proceed with the lamp lighting, please? Along with the esteemed faculty who are present with us, I request everyone to join in for inauguration of the webinar.
Yes, Mr. Prasad, we can go ahead. Yeah. It's all right. We can go ahead. No problem.
I would like to request sir is here, Dr. Alpesh Gandhi sir, to say a few words and give his blessings. And before sir gives his blessings to us, I would like to introduce sir. And sir has been past president FOGSI, and sir has been president FOGSI during the COVID times, and he was revolutionary in bringing in for women's healthcare during
Dr. Vaishali,
those different.
Dr. Vaishali, you are signed in with two devices. There is echo.
Yeah, there is some.
Is there any?
Yeah.
There is some.
No, I have joined only one device.
Please, everybody,
Can you
please.
hear me? Can you hear me now? Yeah, so I just wanted to say on behalf of Dr. Meenu Agarwal and myself, we were very fortunate to work with sir as chairperson FOGSI when sir was president, and we have learned a lot from sir, especially sir had created the FOGSI guidelines, how to manage COVID pregnancy, COVID high-risk deliveries, babies, newborn babies, and so on. So revolutionary work done by sir during his entire tenure. Sir was also a governing council member of ICOG FOGSI, chairperson Practical Obstetric Committee, past president Ahmedabad Obstetric Society, convener of ICOG 2017, which was very, very successful. He has been past treasurer of SOCOG, national coordinator emergency obstetric care, and he has authored books on principles of critical care in obstetrics. Sir's name is synonymous with critical care in obstetrics, and he has received Best Society, Best RCH Activities, Best Publication Award from FOGSI, and RCOG has also awarded him honorary FRCOG. Welcome, sir, and we request you to say a few words and give us your blessings.
Sir, you are muted. You are muted, sir.
Thank you, Vaishali, for the kind words, generous introduction. Let me also inform that I also enjoyed working with all 27 committee chairperson, and I was really fortunate to have so great and so very active committee chairpersons with me. So, and though Charu was not committee chairperson at that time, but I also got an opportunity to work with Charu during the year. And I think though she was not there, but she was the coordinator in all the webinars conducted by BRACE committee during that year also. So indirectly she was there also. So I would like to congratulate Pune team, President Dr. Meenu, Secretary Dr. Vaishali, and Clinical Secretary Dr. Charu for bringing this very meaningful, very important webinar series for our FOXI members. And I would also like to congratulate Pune team, overall Pune Gynec Society for this initiative. I would also like to congratulate Amritsar and Jalandhar team, President Secretary of Amritsar and Jalandhar team for this joint program. It is always good during my tenure also. I was telling that it is always good that few societies come together for some common academic or social interests. So it is always good to see that you all are doing good work, good academic work. I'm so happy to see my two very dear friends, Dr. Ragini and Dr. Asa Bakshi, as the guest of honor. My regards and hello to both of them. And I'm so happy to see the cutting edge webinar. Today we have very interesting topics, fertility preservation, what everyone should know. So this is really very, very important for all of us, that minimum what we all should be, we all should be updated with what we should know about the fertility preservation. And Dr. Meenu is going to speak about it. Next is genetic made easy for every obstetrician. So it's good that I hope there will be few tips to make it easy. And a very eminent speaker, Chinmay, is there, who is the committee chairperson of perinatology. And I think she should do more and more such topics everywhere across India to make this practice, because genetics word itself is everybody's thinking this is very, very something we are not knowing or something very difficult, and we really need to make it easy, or we should at least basic knowledge, all our members should be updated with the basic knowledge. And then we have case study on intrapartum care for safe motherhood. Again, Dr. Meenu is going to speak on it. So three very, very important topic today we have. I think our delegates will be benefited a lot, and we have expert chairpersons, Dr. Surjit Kaur, President Jalandhar Society, and Dr. Shukruti Bansal, Secretary Jalandhar Society, and Dr. Archana Beri, IVF specialist, and Sangeeta, Dr. Sangeeta, Secretary Amritsar Society. So we have a very eminent faculties today, a very interesting topics today. So I think all of our members are going to be benefited a lot, and they will learn a lot from today's webinar. My best wishes to the organizers for this for the success of this webinar, and my best wishes to Meenu, Vaishali, and Charu for their future endeavors. Thank you for inviting me and giving this opportunity. Thank you.
So thank you so much for mentoring me also so well that I could fulfill my dreams, my first step of dream at least. And your wishes will surely help all three of us, do the best for our organization. Thank you for your wishes, sir. Thank you so much for joining.
Thank you.
Over to you, Dr. Vaishali.
Thank you, sir. And we remember you at every point of our work at POGS and at FOXI, and all the things that we have learned from you. Thank you very much, sir.
I
I
also
would
learned
like to
from all
invite
27 committee chairpersons.
yes, sir.
Yeah, we learned a lot from you, sir. I remember you became the Foxy president, and then suddenly this COVID thing came up. So you had double responsibility. One, of course, whatever you had envisioned for your presidency, and second is something new, some COVID thing. You couldn't travel, nobody could travel. So you managed the whole thing. In fact, you made it more successful that year as compared to other years. So that was hats off to you, the way you managed and the way you, kind of just switched gears to COVID, from normal to COVID, sir. That was excellent, sir. Very, very nice, sir.
Truly, sir, the year will go down in history, sir, as maximum number of activities done by Foxy. I think that was a record number of activities done. Thank you for your
Thank you so much.
presence.
Thank you.
Thank you, sir.
Thank you.
I would now like to invite Dr. Asha Bakshi, guest of honor, and I request Madam to say a few words and give us her best wishes. Dr. Asha Bakshi was Vice President, West Zone, and she's Joint Secretary ISAR 2021. She has just finished a very successful tenure as Vice President Foxy. She is founder, chairperson, MP IIG, MP ISAR, past president IIGS, and she was instrumental in organizing AICOG 2021 at Indore, which was immediate post-COVID and a very highly successful conference. And she is also member of Indian Fertility Society, Indian Menopause Society, and she's received many innumerable awards, and she is a big name in IVF, a very well-known, very successful practitioner. So I request Dr. Asha to say a few words.
Thank you very much. Pune Obsgynae Society, Amrit Society, and one more society, the Jalandhar Society. It's an excellent program that all of you have got together. And a warm welcome and thanks to the modern and modest Meenu, vibrant Vaishali, and chirpy and charming Charulata. It's so nice to be on the same platform as our Dr. Alpesh Gandhi, whom I would really call like Ram. So, and he was aptly, I think his Rajyabhishek was done in Lucknow. And that time the theme was Ramayan. And that's how his Rajyabhishek was done. And we all know he is a man with great knowledge, depth and poise. And we have seen him working in the darkest era of the I think Foxy whole world, and that was COVID era. And I think that is most important. And always nice to be with our Dr. Another Dr. Ragini Agrawal, whom I met day before yesterday only. And it's always nice to listen to her, the voice she has, the command she has over the subject, and that's really commendable. And the topic fertility preservation, and I think this is very neglected topic. And most of us these days we talk fertility, but we forget about fertility preservation. And with rising incidence of cancers, with rising incidence of deficiency in gametes, I would say that word only, because most of the patients that we see either they have premature ovarian failure, diminished ovarian reserve, men have oligoasthenozoospermia. So I think it's very important that we get sensitized towards it. And even in patients of endometriosis, all these patients, they need to be counseled in advance for their fertility preservation. So this sensitization for every gynecologist is a must. And genetics, again, a topic which is very complicated, and I'm sure Dr. Chinmay, she's going to really simplify it, and simplify it in such a way that each and everyone can practice genetics. Because today a modern obstetrician and gynecologist, you have to know all these things. So, and again, that case presentation on obstetrics is going to be helpful to all of you. So it's really nice, a very well selected program, and thanks again for inviting me. Thank you.
Thank you so much, Bakshi ma'am. It is always a pleasure, to work with you, be with you, and you spread so much of positivity and affection, along with the radiance of your knowledge. That it is really a pleasure to have you as our guest of honor for today. So thank you for sparing your valuable time to bless this webinar. I think that Dr. Ragini ma'am has not been able to join. So. Dr. Meenu, I think we'll take this opportunity to thank Dr. Alpesh Gandhi sir and Dr. Asha Bakshi for being here, for blessing our cutting edge webinar. And with a very big thank you, we move ahead with our academic program.
Thanks. I would like to take your permission because I'm traveling, so I think I'll just stop my screen share.
Thank you very much for your kind words. Very generous for all of us. And
all the best, Meenu. Meenu, all the best for your future endeavor. And I'm sure you are so hardworking and so sincere. You are going to do very well. So keep working hard, and I'm sure you'll achieve your aim.
Thank you very much. Thank you. Thank you for your blessings. Thank you.
Bye. Bye. Bye.
Let's move towards our first session. For chairing this session, I would like to invite Dr. Sukriti Sharma, madam, and Dr. Surjit Kaur, ma'am, for chairing the session. So, Dr. Sukriti Sharma, she is the secretary of Jalandhar OBGYN Society. She has many feathers in her cap. She is the member of ESHRE. She is member of ISCCP. She is member of she's member of IAGE and FOXY. She has participated in many workshops. She has presented a number of papers. And she has done her laparoscopy and ART fellowship from Surat, and she has also trained in hysteroscopy by workshop from Dr. Osama Shauki, and I think the list just goes on. I would now call upon Dr. Surjit Kaur madam, and I would request Dr. Vaishali ma'am to introduce her.
Yeah. Thank you, Dr. Madhura. It's an honor to welcome you, madam, to chair the first talk by Dr. Binu Agarwal. And Dr. Surjit Kaur, madam, is President Jalandhar OBGYN Society. She's past chapter secretary Jalandhar Menopause Society, FICMCH, gynecologist and obstetrician, laparoscopic, hysteroscopic surgeon, colposcopist, and an IVF specialist as well. Madam, we are truly grateful to you for Jalandhar OBGYN Society for joining with Pune Gynaec Society and along with the Amritsar OBGYN Society for this particular webinar. Welcome, madam.
Shall we introduce the second chairperson, because I don't see her?
We did, ma'am.
Dr. Surjit was here, I think. Dr. Surjit and Dr. Sukriti.
Dr. Sukriti.
Yeah. So can we proceed with the talk? Madhura, will you introduce?
Okay, ma'am.
No, I can see Dr. Kamalpreet Kaur and Dr. Anuchit Kaur Randhawa and Dr. Raj Sinha.
Okay.
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 Okay, so I would like to introduce Dr. Meenu Agarwal ma'am, who needs no introduction. All of us know, but I would just like to enlist her achievements. So currently, madam is the president of Pune Obstetrics and Gynaec Society. She is the elected General Secretary of International Society of Gynecological Endoscopy. She was the ex-chairperson of Imaging Committee of FOXY, and ma'am has won a number of awards. India's Greatest Leaders by Asia 1, Icon of Health by Times Group, and FOXY Champion of FOXY Award. So we cannot wait to hear from you, ma'am, for a very interesting topic, and which will benefit everybody who is listening. So over to you, ma'am.
Thank you, Madhura, for very nice introduction. And All right.
Pleasure.
So thank you very much, and thank you Vaishali, thank you Charu, thank you all the all our esteemed guests, chief guest Dr. Alpesh Gandhi, and guests of honor Dr. Asha Bakshi Madam and Dr. Ragini Agarwal Madam, who probably couldn't join because of her flight schedule. So today my talk will be on fertility preservation. So when I say fertility preservation, what is the meaning? Meaning is we are freezing the eggs of a woman, right? That could be because of social reasons, number one. Second, it could be because of some kind of cancers that she has got. She's got to go for chemotherapy, and we need to preserve her fertility. And thirdly, some conditions which are not cancers, which is not social, and yet we want to preserve her fertility. Very unique conditions, enigmatic conditions like endometriosis. So I will be discussing all three one by one. Now, when we talk about the social egg freezing basically is because of the end of the hours. That means there is a biological clock which is ticking all the time, which is reducing the fertility of a woman by the day, by the month, by the year. And yes, just one moment. I'm sorry. So that one of the reasons can be there. Now again, there was some news that Apple and Facebook, they are paying their employees that you freeze your eggs and we will pay for you. Why? Because they do not want them to quit the jobs. They do not want them to, probably, which was actually explained by the other lobby, that they don't want them to take maternity leaves. So they are just encouraging them to freeze the eggs, which is actually not taken in a good way by many organizations. So freeze your eggs, free your career, and why you should freeze your eggs, and why some people were very happy freezing the eggs. So all these things are there. And is it sending a wrong message to women? Probably yes, when the Apple and Facebook are telling them. However, when we are telling them as doctors, we know who should freeze their eggs and why they should freeze their eggs. So time is not our friend. There is always a conflict whether I should have a child first or whether I should move up in my career. Or a lady gets married, but the person is not Mr. Right. She's again single. She's again running behind the time. So what to do about the fertility? So that is again a question mark. So the rush hours of life, time is, between 25 and 35. That is what we say a girl should have a child, but the time is running out very, very, very fast. So if you look at this, is a study from Europe. In 1970, the first child was born at the age of around 24, 25. In 1990, it is around 28, 29. In 2009, it is around 29. And the recent studies have shown, even in India, even in the eastern part of the world, the first child is born after the age of 30. So that is going ahead, the age of the childbirth. And we also understand that the fertility decreases with age, and there are increased number of women who would have delayed their childbearing. So another thing, now suppose I have a girl, she is 32, she has frozen her eggs, she only gets married at the age of 39. So should she go for a fresh, and she has to go for IVF for some other reason, should she go for IVF with her eggs at 39 or at 32? So we all know that the younger eggs have lower chances of aneuploidy. Dr. Chinmay will be talking about genetics, but this is a very, very simple genetics that we all understand, that the younger eggs' chances of euploidy are more as compared to the older eggs. So aneuploidy increases with age. You can see over here, this is at the age of 35 and this is at the age of 43. The euploid eggs are so few at this particular age, the percentage wise. And the aneuploidy goes up as the age advances. Again, the ovarian reserve goes down as the age advances, the follicle count, the FSH goes up, the AMH goes down, and age again. When we talk about all the surrogate markers of ovarian aging, most important is the age. Biological, somehow I think nature has also not been very kind to women as far as the fertility is concerned. So the Prince Charles could have babies even at the age of 60, 65, but Camilla Parker could not. So they could not have any children of their own. Then we, of course, even when we talk about ART, बहुत बार पेशेंट्स आते हैं, बोलते हैं कि अभी तो कोई बात नहीं हुआ और वेट करेंगे, बाद में अगर नहीं हुआ तो IVF करेंगे. But we have to tell them that age, even with IVF, as the age advances, the pregnancy rates go down because the egg quality is not so good. So if somebody has frozen their eggs at a younger age, that egg will have a better chances of conceiving, of fertilizing and implanting as compared to the older eggs. So these we have to consider. And now why suddenly we are talking about egg freezing? ये हमने 10 साल पहले, why did we not talk about it? Because now we have vitrification. Earlier we had slow freezing. तो slow freezing में क्या था कि अगर हमने 10 eggs freeze किए, so we would, when we thaw them, we would only get 6 or 5. But now with vitrification, it is a fast freezing. There is no icicle formation, and then the recovery rate is very, very high. So how many ever eggs we freeze, 90% we can get these eggs. So egg freezing is as good as fresh eggs. Very, very good study. I will not go into this sibling oocyte study. You can study about it, that whether we use fresh eggs or we use vitrified oocytes, it does not increase aneuploidy, and the baby is born out of frozen eggs also do not have any increase in the anomalies. So now there are some studies where they have said that egg freezing is it experimental or is it required? It is required for the society. अभी फॉरेन कंट्रीज में क्या, वेस्टर्न वर्ल्ड में IVF इज फर्स्ट साइकिल, सेकंड साइकिल इज कवर्ड अंडर इंश्योरेंस, बट दे डोंट वांट टू कवर द oocyte freezing. उसको कवर, दैट इज व्हाई दे से oocyte freezing is still experimental. However, all of us, all IVF centers, we are, including ours as well, we are all doing oocyte freezing with very, very good results. In fact, मेरे friends के all their children, their daughters, like 34, 35, still looking for the right man, guy, or not wanting to have a child, I have frozen their eggs. I said, you do whenever you want to have a child, you have, but at least you freeze your eggs. So that is always a good option that can be given. Also, patients who are born with Turner syndrome. Turner syndrome में क्या होता है कि they have good number of eggs, but very soon the egg reserve goes down. Also, girls where mothers got menopause at the age of 35. Today only I had a patient, only 29 years of age, AMH is 0.3. Mother had menopause age. This girl she frozen her eggs at the age of 24. It would have been so much better for her. So these are all social banking. Again, how many eggs to freeze is again a very difficult question. But generally we say that at least 10 to 15 eggs we should freeze to at least get a good one live take home baby, one live birth. So uske liye 10 to 15 eggs we must freeze at one time. So again, a lot of patients like Diana Hayden, she was there, I think in Lucknow or in Hyderabad for the AICOG, and she came up on the stage and she said, I had a child. She was with the Bloom IVF with Rishikesh Pai and Nandita, and because she had frozen her eggs. So she froze her eggs. She got married at the age of 37 and she had 2 children out of the frozen eggs. So I think the celebrities should come out and they talk about it so that the normal people also get motivated and they get convinced. हम लोग डॉक्टर्स बोलते हैं तो कभी कभी लगता है कि मे बी there could be other reasons, or they don't even come to the doctor before we can counsel them. So at least it brings them to the doctor and then we can counsel them in the right way. Then again, then this is about the social egg freezing. Then we come to, now suppose this is a lady, she's 33 years old, not married. She has severe dysmenorrhea, dyspareunia, bilateral endometriomas, 4 centimeters, 5 centimeters. Medical management given, she did not respond to medical management. AMH is 2.9. So I'm sure everybody will agree that she probably needs a laparoscopy surgery. But we also know that she is 33, her AMH is 2.9, generally 30 to 40% drop in AMH, and there is a possibility that by the time she gets married and want to have a child, these endometriosis could come back, or this particular surgery could have an effect over her ovarian reserve. So this is the girl where you can, of course, talk to her about the surgical part, but also counsel her for the egg freezing for her future childbearing. So now fertility, I think I have been talking about fertility preservation in endometriosis for a long time, but this time even in ESHRE, they touched this particular topic on fertility preservation in endometriosis. Very, very good option. Can preserve the embryo if she has a steady partner or a husband, or the egg if she does not have a partner. So we can either freeze the oocyte or the embryo, which is mostly done. There is also an option in ESHRE, they have mentioned ovarian tissue freezing, which we are not doing routinely. However, that is also an option for these patients. Then, of course, there is fertility preservations after cancers. Now, very, very difficult situation. A girl comes to us, she is 29, for example, and she comes with a lump in the breast. You palpate her, you do a FNAC. I think Charu will be the right person to say about it. You do a core biopsy, and it turned out to be malignant. What next? The first thing they say is you manage the malignancy. We don't care about the pregnancy. So, and you the oncosurgeon or the breast surgeon or the gynecologist, I think, should, very, very important, that these patients should be referred not only to the oncosurgeon, but also to reproductive endocrinologist and the fertility specialist. They have to be counseled, because this is not today's problem. She will come out of the breast cancer, but she will have taken chemotherapy and surgery and everything. And by the time she realizes that, she's out of all of this, she again goes into the pit of infertility. So that should not happen. So they need to be counseled. Again, very important, it is not that she has to wait for her cycles to come. Day 2 से stimulation शुरू करने, ऐसा कुछ नहीं है. Random start. Today she is diagnosed. From today we can start her on stimulation, and we can still freeze her eggs, and then she can go for the surgical procedure or the chemotherapy. So we need to assess her, of course, with FSH, AMH, AFC counts, and fertility preservation women with cancers. I get, sometimes it is I feel very, very sad for our community, myself, because I have had patients, male factors, the husband who's had some kind of chemotherapy done for something, and the semen was not frozen, the semen sample. That is such a simple thing to do, actually. But sometimes oncosurgeons are doing their job very well. But this has to be kind of conveyed to them that this should be done before young adults, young men, before we take them for bone cancer. So they put them on chemotherapy, and it fires the testes, and then we don't get, then they have to either go for a donor sperm. But just a simple thing of freezing a semen sample could have done a good job for them. So we have the possibility of oocyte freezing, embryo freezing, even immature oocytes. Suppose she does not want to wait even for 1 week. There are follicles, antral follicles as they are called. There are immature oocytes in there which can be frozen. Now there is another thing which has come, that you take the ovarian tissue. Okay, ovarian tissue निकाल के उसको freeze कर दिया. Now that suppose she has an ovarian cancer, we cannot put that ovarian tissue back into her. because there can be a flare, there can be a recurrence of the malignancy. This ovarian tissue can be subjected to gonadotrophins outside in vitro, and the follicles can develop and we can harvest the oocytes. So this is something which is amazing work going all over the world. It will come in some time. I think we will also have access to all these work. And of course, we must understand when to refer the patient, which patient to refer. Oocyte vitrification is a viable option for the patients. And of course, oocyte banks, sperm banks, maybe we will not require once we have a better way of getting the eggs. Even there are some studies where you can even convert primordial follicle, which are there till the age of 50 years of age. If there is some way we can convert these primordial follicles into antral follicles, so that is the cycle which gets stopped after she stops ovulating. So if that is also work is going on, so maybe those options will come back to us. So all this we have to keep in mind. We do not want women to become pregnant at old age, but what we want is give them the option that if they want to have a childbirth little later in their life, it is possible, and it is possible to do it, and they don't have to go for a donor egg if required. So thank you very much for listening to this talk. It is a little different talk that I put up this time, and if there are any questions, we can take them. Thank you very much.
Thank you, ma'am. If the chairpersons are there, could they give their comments or?
Excellent talk, Dr. Meenu. It's always wonderful to hear you speak, and your depth of knowledge and your command over the topic is superb. And we wish you all the best for Vice President Foxy election. So all of us are with you, and you deserve this post. So all the best to you.
Thank you, Vaishali. Thank you for your kind words always. Thank you.
Madhura?
Yes. Okay, so we move ahead to the next session. Thank you, chairpersons. So for the next session, I would like to call upon Dr. Sangeeta Pahwa, who is the Secretary, Amritsar Society of Obstetrics and Gynecology, and Dr. Archana Beri, ma'am. I don't know if ma'am has joined.
Yes,
Yes,
madam is here. Yes.
Yes. So I would request Vaishali ma'am to introduce Dr. Archana Beri.
First of all, Pune Obstetric Gynec Society is truly honored to be associated with Amritsar OBGYN Society and Jalandhar OBGYN Society. And especially for this talk by none other than Dr. Chinmay, who is the master and the biggest expert in the topic. And whatever Dr. Chinmay speaks is like mesmerizing, and so much to learn from her. So to chair these talks, I request Dr. Archana Beri. She is president of Amritsar OBGYN Society. Dr. Prasad, can you put the correct CV? Yeah, Dr. Archana is consultant OBGYN and IVF specialist at Berry Hospital, Amritsar. And she has various affiliated to various societies, IMA, Foxy, IFS, PPS, FML, many societies. Her area of interest is high-risk pregnancy, hysteroscopy, laparoscopy, fetal medicine, and she has many publications and a chapter in high-risk obstetrics. Welcome, madam. I would also like to welcome Dr. Sangeeta Pahwa. She is Secretary, Amritsar OBGYN Society, and she has delivered various lectures on various topics. She has chaired and been esteemed faculty at various conferences. And she has done training in infertility, IUI, laparoscopy, and hysteroscopy. And she has been awarded second prize in International Women's Health Summit in Delhi at Delhi 2018. She has 20 international publications in Index Journal. That's amazing. She is lifetime member of Foxy and International Journal of Gynecoplastic Surgery. So welcome, Dr. Sangeeta. And I request the chairpersons to take over and invite our speaker.
Thank you so much, Vaishali, for kind words. And I congratulate Pune Obs Gynae Society for organizing this webinar that is cutting edge. And thank you so much, Meenu Agrawal ma'am, for such a nice and wonderful presentation on fertility preservation. And we all are with you, as Vaishali has rightly said, and best wishes for your endeavor. And I would like to invite today's speaker, Dr. Chinmay. Can I have CV of Dr. Chinmay Mathur? Yes, Dr. Chinmay is Director, Resolution Fetal Medicine Center and Research Institute. She is Senior Consultant, Fetal Medicine, Yashoda Hospitals, Hyderabad. She is Chairperson, Perinatology Committee, FOGSI 2021 to 24. She is President, SFM Telangana Chapter, Member, Scientific Committee, IMA Telangana, Member, IRC, AICC, RCOG South Zone. Shiva has been awarded with Dr. C.S. Dawn Award First Prize AICOG Hyderabad 2024. Professor Kamal Bakshi Oration in Fetal Medicine New Delhi 2023. Dr. V.N. Shirodkar Oration Award Solapur Society of OBGYN 2022. Asia GCC Award for Excellence in Healthcare Leadership 2021. APJ Abdul Kalam Award for Service during Pandemic 2021. Dr. Rajat Rai Fetal Medicine Award FOGSI 2019, Wonder Foxian Award 2019, FOGSI Young Author Award for the Best Paper Published in Jogi in 2008, Best Paper Prize at APCOG 2005, OGSH 2004, CS Dawn Gold Medal 2003. She has co-authored two books, that is on the fetal medicine and SBN EMQs for MRCOG2. Over to you, Dr. Chinmay, for your wonderful presentation. That is genetics really complicated, and you are going to make it simplified. Over to you.
Thank you. Thank you so much, Dr. Sangeeta. And it's really a pleasure at the outset to be here with Pune OBG Society and Amritsar and Jalandhar, and that is the marvel of technology. So can I just share my slides, please? And I thank Meenu Madam and Dr. Vaishali for this invitation. As we've just said, technology is very marveling, but when it really comes to genetics, I think all obstetricians have a bit of cold feet. Although I find infertility and all this fertility related technology, which Madam was just talking about, extremely overwhelming, and I think that's even more difficult than what we do. Thinking about taking the ovarian tissue, putting it in some other solution, making an egg there, and actually transferring genes into another generation is fantastic. But what are these genes all about? Whenever we want to reproduce, we want to transfer our characteristics into the next generation. And we know that all this happens through genes. But when you take genetics, everybody's worried. What is genetics? I don't understand. So we understand that the fundamental reason for reproduction is transfer of genes from one generation to another. So genetics itself is the study of genes, and genes are the carriers of hereditary characteristics from one generation to another. Understanding how these characters go, what is the mode of transmission, and the technology problem in a certain individual, and then advancing to treatment. That's all the remit of genetics, as we call it. And many of you say very well, why should I learn genetics? Many of you must be thinking, yaar, ye to zabardasti humko genetics padha rahe. You are a clinician, genetic conditions and all these, whatever we have discussed, they present as clinic for your patient. If you do not recognize the underlying genetic etiology.
It's breaking, I think.
And whether you like it or not, the action from modern day doctors is. So suppose you are called Mrs. Pale in her pregnancy. You realize that her hemoglobin was 7 gram%. I am sure none of you will be surprised, because we are working in India. 7 grams is not a big deal for us. You gave her iron preparations, you gave her deworming protocol, encouraged her to take iron-rich foods. The hemoglobin remained low. So you gave total dose iron and somehow managed her, pregnancy. There was a fear of iron overload, but then she had a condition called genetic in origin. The carriers of these conditions remain with hemoglobin despite iron, and overdose of iron can harm them. You came to know about this when you did an HPLC. So you somehow treated her, understood this condition, took very good care of her, and delivered a 2.75 kg baby girl who was apparently healthy at birth. According to you, you've done a great job. A very, very anemic patient, you've taken care of her very well. She has a hemoglobinopathy carrier status and you care of her. But 8 months later, the parents returned with the baby because baby has persistent anemia more severe than the mother, needs frequent blood transfusion, and recently when they were physician and got it tested, it has come out to be thalassemia major. They ask you that, doctor, could you have detected this beforehand? So despite your best intentions, harm was done here. Why? Because you were not aware that this condition which the lady has is a genetic condition, and unless her husband is also a carrier of this, which you have not ruled out, you are dealing with a situation where the baby can have a major genetic condition. So thalassemia is an autosomal recessive disorder. People with thalassemia genes can be carriers, just like this woman was. She had mild anemia, but she was leading a normal life. Her husband may not even have had mild anemia because men don't have that much of blood loss during pregnancy or menstruation or anything, and therefore their reserves are better than women. So he may pass off with a hemoglobin of 10, 11, 12, and he will never know that he's a carrier. But because he and his wife were both carriers, if you see here, there is a 25% chance of the final baby being affected because the baby has received both abnormal genes from the parents. And that is what happened in this situation. And it could have been prevented aware what we were dealing with. So prenatal diagnosis was also possible, and this pregnancy could have been terminated instead of them having a baby with thalassemia major. So the reason we went wrong here was we didn't even anticipate that there is a possibility of this condition. If we had anticipated, we could have done prenatal diagnosis. How do we do prenatal diagnosis? We put a needle inside the gestational sac and take a sample like amniotic fluid or chorionic villus sampling, and then obtain fetal DNA, which we send for analysis. Again, DNA. The word itself scares us, but we read about it in school. So remember, DNA is nothing but a whole strand of biological information. And those informations come in these codons, which you have there. And these are the simple base pairs, the adenine, guanine, thymine, and cytosine, which form corresponding parallel groups there. And how you read each and every code tells you what the gene will be. So a gene is nothing but a strand of DNA. DNA is the biological information. This opens up, matches with some kind of RNA, and finally RNA goes on and makes protein. So that is the flow of biological information which we read even in school. Wrong DNA, wrong protein. So one gene, one protein hypothesis, which we had read long time back. So when we do sequencing, we read the entire sequence on the DNA. So that is what is called gene sequencing. And it's packed together, it forms a structure called chromosome. So chromosomes also have genes, but they have the genes in the non-functional state, where they are just transferring genes from one cell to another at the time of cell division. That is the time when chromosomes are formed. But when the cell is active and things are going on, they are like strands of DNA. So the first and foremost thing I want all of you to understand is the difference between chromosomes and genes. So genetic condition, single point mutation, point deletion, some kind of gene related issues, not chromosome related issues like thalassemia, muscular dystrophy, many conditions which lead to developmental delay. And here we screen by history, but workup. Double marker test, triple marker test, quadruple marker test does not screen for genetic conditions. They screen for Down syndrome. Whenever we talk of prenatal screening, we think only of Down syndrome, but Down syndrome is a chromosomal abnormality. And this is the set of chromosomes that we have in our body. So we have 23 pairs of chromosomes. The last one is the sex chromosome pair, which is XX or XY, but the other 22 pairs are similar autosomes. In Down syndrome, you have 3 sets of chromosome 21 instead of 2, and hence that is trisomy 21. It is a chromosomal abnormality. The chances of having Down syndrome are 1 in 1,000 to 1 in 700 just in the population, because every time you form a baby, the chromosomes are broken and divided into 2 cells. When that does not happen, you have aneuploidies or abnormal number of chromosomes, and that is what is Down syndrome. What are genes and what are chromosomes? So genes are stuff when you are actually working, when the units are working. This is a busy kitchen. So all the food that is being made there, all the trays, all these are all different types of genes there. This is a busy person working on his desk. Each and everything can be considered as a gene. But what is chromosome? When this thing has to be packed and moved to some other thing, what do? You put all that stuff into boxes. So the boxes are the chromosomes which carry the genes. So when you do karyotyping, you count the number of boxes. If you have to do gene sequencing, you have to open up all these things and read each and everything which is given there in the box. So there is a division between gene and chromosome. Genes are carriers of heredity. They have small sections of DNA which are responsible for formation of particular proteins, but all these genes packed together in a structure so that everything can move from this cell to the next cell is known as a chromosome. Chromosomes contain genes. So this is how it is. You have a chromosome. It's a tightly packed genetic material in a particular shape here. But when you open it up, it has nothing but strands of DNA. And you need to just read each and everything to find out where the genes are in that DNA. So this another example will make it clear for you. Karyotyping is counting the number of books on a bookshelf. So if a book is missing or a book is extra, you will come to know. So for Down syndrome, we can do a karyotyping because we will know that there is an extra chromosome. But for micro deletions and duplications, for example, if one of the pages is missing, you won't know on the karyotype. For that, you have to do microarray. It's like counting the pages of the book. So if the page is missing, you will come to know. But is the page important? Is the page relevant? You don't know until you know which area it is missing from. So if you're missing the page where the publisher's information is there, not a big deal. But if you're missing the last page of a suspense novel, big deal. So similarly, you come to gene sequencing. Gene sequencing is reading each and every line of a book. But it takes a lot of time and you read so much nonsense before you get to the actual material. So gene sequencing is a very tedious process, but it gives you a lot of information. But if you want to do something very fast, you know that on such and such page, you're looking for this word, then you can go directly and check whether the word is present or not. That is targeted mutation analysis. So you know the sickle cell anemia mutation, you know that valine has been replacing with glutamic acid. You go to that area, you see whether it is valine or glutamic acid. You know that it is sickle cell anemia, yes or no. So these are the different types of genetic tests that we do. Karyotype is the number of chromosomes. Microarray is a high resolution karyotype. So this is just a chromosome where you can count the number. In microarray, you get a lot of high resolution information. So this is a high resolution image. This is a low resolution image. This is the difference between karyotype and microarray. So small deletions, duplications, micro deletions, duplications can be detected by microarray, which you do not detect by karyotype. So microarray gives a little more information than what karyotype gives. How does a microarray report look? It looks like this. So it will tell you cytoscan 750K. What is it? The CN is copy number status gain. So there is a gain on chromosome number 21 and there is more chromosome 21. So this simple report of trisomy 21, which was looking like this on the karyotype. If you see here down there, 3 chromosome 21s, instead of that, you get a report like this, which says gain on chromosome 21 pathogenic. So there is this is a normal CMA report where you do not see any kind of gains or losses. There is no Down syndrome, no Edwards syndrome. It is little different from the regular karyotype report that you see. It's a high resolution thing, and therefore it also comments on the micro deletions and duplications. So Down syndrome is a chromosome abnormality. This is how it will look on karyotype, and this is how it will look on microarray. But the information that you get is the same. Microarray gives a little more information. So if you start doing microarray for everybody, you will get some or the other extra information. For example, this is Mrs. XYZ, gravida 3 para 1 L1 A1. First child was a preterm delivery, PPROM 1 kg, succumbed after 15 days. Referred at 16 weeks, 6 days for a gestation related increased risk for trisomy 21. And we did a trisomy 21 counseling and did an invasive test. Sample was sent for QFPCR and CMA. QFPCR is quantitative fluorescent PCR, quick report for Down syndrome, Edwards syndrome, all these major aneuploidies. So on QFPCR, like FISH, there was no abnormality. But then when we did the karyotype, we found a loss, that is a deletion on chromosome 15. On karyotype, this would have been normal, mind you, but now there is a deletion in chromosome 15 and it says it is pathogenic. So this sometimes gives us a lot of, anxiety, because we checked for Down syndrome, but we found something which is not related to Down syndrome. However, when the interpretation is pathogenic, it is attention to it, because this may be a cause of mild developmental delay or something or the other. And if you as an obstetrician do not understand this, send them to a clinical geneticist, send them to a fetal medicine specialist, so that at least this gets addressed. You cannot brush it under the carpet because it may be some important. It has been said now that in unexplained fetal growth restriction, if we do copy number variation or microarray, we may find a 5% in extra information about the cause of unexplained growth restriction. So there are a lot of things which are coming in the pipeline. We don't know whether we should put it into clinical use immediately, but there is a possibility. Then comes the other information called FISH. What is FISH? FISH is fluorescent in situ hybridization. How is it useful? Now, when you do microarray or you do karyotyping, it takes a long time to culture those cells. But suppose you want a quick result and you just want to know whether there is trisomy 21 or there is no trisomy 21. Then what you can do, you can label a portion of the chromosome with a particular primer and put fluorescent color there. And when you see, this is how the report looks like. Can you see this colored marks here, which are fluorescent? So you can count the number of chromosomes. And if there are more number of dots than expected, you know that there is a trisomy. Or if there is less number of dots, you know there is a monosomy. So FISH is also another method of getting quick results. So genetics sometimes looks like a Rubik's Cube. You don't know whether you're really doing the right thing because you have to put so many things together. So the basics should not be forgotten. We should not forget that genes are nothing but strands of DNA, and DNA is the ultimate biological information. These genes are packed into chromosomes, and the place of the chromosome where the gene is called the locus of the gene on the chromosome. Are you remembering? You've read all this in school. So the locus of the gene in a chromosome is the place where the gene exists, and every gene in our body has two homologous pairs. They come from each parent. And sometimes we may have the same gene we may inherit from both the parents when we are known as homozygous. And if we have a different gene, then it is known as heterozygous. So if suppose we have the same gene, the final phenotype will be just the same. But if we have a different gene, suppose one is red and one is white, then whether the flower should be white or the flower should be red, that will depend on which character is dominant over which character. So if both the genes are white, it will be white. If both the genes are red, it will be red. But if one is red and one is white, then what is the final color? The final color could be white or red depending on who is dominant, or it could be a third color called pink if it is co-dominant. So the phenotype and the genotype, there is a little difference. And this we had read in school. Gregor Johann Mendel, the father of genetics, had done these experiments where he crossbred peas, and he decided that whatever is the dominant character that presents itself, whether it is alone or whether it is in combination, whatever is the recessive character will only present if it is all by its own. It's the same, loud people, you will hear them talk all the time. The quiet people, they will talk when there are no loud people around. So that's the rule even in genetics. And what we do here is, if it is dominant, you will see that character in every generation. So this diagram is known as pedigree. Again, the moment I say pedigree, many of you will think, oh my God, this is too complex. But it is not. Just look at it. If the character is there, it will show as a fully colored circle or a square. Circle and square are men or women. And then when they transmit through generations in autosomal dominant conditions, you will see that character in almost every generation because it's such a dominant character. It can't hide. Whereas recessive characters may skip generations. So you may have multiple people who are silent carriers, and therefore people will say, oh my God, how did we have this problem? Nobody in our family has the problem. Well, somebody is carrying the gene. You have not detected and therefore you do not know. So recessive conditions can manifest, especially in conditions like consanguinity, where the common genes may be present in both the partners. But otherwise, we have a very, very sturdy genetic pool in this country, and it is not very common to have genetic conditions in all communities. Then comes the concept of dominance in blood groups. And here we understand co-dominant. So O and A, there is a clear dominance, but A and B, both are equally dominant. And therefore, there's a fourth kind of blood group called AB, when both A and B genes are present. So these are common examples which I am reciting again and again so that you understand the concept of dominance. You understand that genes play a very, very vital role in our metabolism. So every genetic component may not be expressed. We have X-linked recessive conditions like Duchenne's muscular dystrophy, hemophilia, but sometimes even a female may get affected by these conditions. How? Either she's carrying both the abnormal X chromosomes, which is extremely rare, or the normal X chromosome has got, lionized or inactive. So the gene presence and gene expression can be two different things. Not to get confused, because the point is it is confusing, but then we should know that this can happen. So when the patient says, how did this happen, madam? You thought this will not happen. You have to tell them that, look, I cannot predict everything because these are the ways genes work. So the fact that this is working for you or this is happening to you is not because I am foolish. It is because this particular condition travels like that, and we cannot predict beforehand whether the gene which is present will express or not express. So what we must remember, that whenever we want planning genetic tests, we should know the index case diagnosis. We should have preferably the molecular diagnosis explained. We should have optimum testing conditions, availability of lab facilities, and a clear plan for modifying pregnancy care. For example, this is a 27-year-old lady who has a first child who's taking multiple transfusions. You remember the example I gave in the beginning. And now we know that that is major beta thalassemia. So we know this is how it transfers. So what we do is we check the mutations. So this is how the mutation report will look like. So we have done the mutation in the parents, and we know that this is the mutation, this is the base pair fragment, and this is where we have detected beta thalassemia major. And therefore, we go ahead and do a CVS or an amniocentesis, and then we check it in the baby. This is a condition where the first child had a mutation that is autosomal dominant. That means the child has a particular mutation, but the parents do not have that mutation. And now they are pregnant the second time and they ask you prenatal diagnosis. Should we do prenatal diagnosis? Because the first time that the child had the mutation is probably a single mutation in the child. However, we cannot rule out that the parents are also carrying some unknown gonadal mosaicism, and therefore this also makes a case for prenatal diagnosis. If the couple wants 100% diagnosis, then you can still offer them prenatal diagnosis. But what is the problem? Suppose you do prenatal diagnosis and check for all genes. Nowadays, it is a very common practice. Send for whole exome, send for clinical exome. Suppose you detect one of these conditions, retinitis pigmentosa, Huntington's chorea, or some other condition which may not manifest now, but may manifest at 40, 50 years of age. So I always tell you to remember that Vivekananda died at the age of 40 years. Swami Vivekananda was alive only till 40 years. So if he had a gene that would cause problems at 45 years of age, why would we have terminated him as a fetus because that gene was detected? And if we had done that, we would have lost Swami Vivekananda in this entire universe forever. So there are a lot of ethical dilemmas in doing prenatal diagnosis, and that is why the Rubik's Cube gets more and more complex. And we should always remember, in autosomal dominant conditions, there are a lot of uncertainties. So the decision to terminate pregnancies for these kind of conditions has to be a very considered decision, and something that comes with a lot of counseling, preferably with a clinical geneticist. So wherever index case workup is possible, we should do that. We should check the parents for carrier status and have a targeted genetic diagnosis only with a plan. Without a plan, genetics can make it very confusing. Sometimes we get cases like that where previous children have had multiple neurodevelopmental delay, and then suddenly they're sent to us at 12 weeks for doing CVS. The obstetrician says, please do CVS because this child is having a lot of problems. What is the problem? We don't know. We can't just do CVS like that. And they tell us, anyway, you want to do for Down syndrome, no, wohi check kar lo. But if you check for Down syndrome, that is not going to solve her problem because she has previous problems for different reasons. So here, you have to get a carrier status done for the parents. Like in this particular case, we did a carrier status and found that the parents were carriers of a condition called gangliosidosis. And then we got a prenatal diagnosis, and unfortunately, the fetus was found to be affected. So in genetics, always go step by step, look at the clues, find out who is a carrier, see if the mode of inheritance justifies prenatal testing, and then only do prenatal testing. There are sometimes affected parents themselves and they want the best for the child, but that may not be needed. This was a mother who herself was compound heterozygote, one gene of sickle cell, one gene of thalassemia. She was in a very bad medical condition, repeated blood transfusions, lot of problems, but she got pregnant. And then she was sent to us for prenatal testing. But we did not need to do the prenatal testing because she herself has two abnormal genes. Husband has both normal genes. So all her children will end up being carriers. They will not be affected. And therefore, she does not need prenatal diagnosis because none of her children are going to be affected if her husband is normal. So this kind of understanding of autosomal recessive conditions is very important. Basic pedigree, testing the index case, identifying the genes that are necessary, and understanding how to plan prenatal diagnosis in genetic conditions, very important. And the best time to do this is before conception. So all the obstetricians should remember that routine evaluation in these cases is very important. Anything, we will be encountering this more and more in our clinics, and we must have a thorough knowledge of the basic principles of inheritance. Try to update ourselves because that is an expectation from our patients. Whenever in doubt, work in close coordination with the clinical geneticist, store DNA in cases where you don't know what is the problem that is happening, and do preconceptional or interconceptional investigations to plan prenatal tests. So the ideal test, suppose there's a previous child with Down syndrome, then you can do an amniocentesis, karyotype, or CMA. If there are multiple structural malformations, preferably do a microarray. Previous child with Gaucher's disease or some kind of genetic condition, do a mutation matching. Previous child with seizures and mental retardation, check the first child first. Do carrier status and then cryoanalysis with whole exome sequencing if necessary. So the fact is we cannot find everything, we cannot explain everything, we cannot prevent everything, but we have to do something because doing nothing is no longer an option. Information is power. Our people want information, and this solution of genetic problems needs a lot of patience. And what we have to do is understand that, each and every genetic test brings us a lot of information. So whether we are overdoing these tests, that is a question we need to ask ourselves. Do we need all this genetic information? Because there is a lot of ethical dilemmas in all these conditions. And therefore, before doing all these tests, we have to have a clear discussion with the parents. Genetics can be very good, but if we mess with genetics, we will create creatures which we cannot handle. And the first principle of medicine remains, do no harm. So all of us should understand the basics of genetics, should use it for the betterment of our patients, try not to confuse the patients, but most importantly, update ourselves because that is the basic requirement of medical practice in today's time. Thank you very much. Any questions? I'm happy to answer.
Thank you, ma'am, for such an enlightening speech. So it was very enlightening and very informative. And as an obstetrician, we have very tough time whenever there is this problem like this. Like my patient was having Duchenne muscle dystrophy, and I couldn't have any idea how to approach it. So I think my doubts are clear that DMD is a single gene disorder, and I think we should go for that. WES.
Go for a carrier testing.
And then.
Yes, madam. Yes, thank you so much for understanding that. And
yeah, so I have understood little bit. So how to approach such patients?
Sure.
Thank you so much, Dr. Chinmay. We have recently encountered one patient where a genetic counselor people did the counseling, and we have published this paper in Jogi. And in March, this paper will come out, that importance of the prenatal genetic counseling and experience with the hereditary thrombocytopenic purpura, where patients were
Absolutely.
counseled properly. Yes, there we did with the help of the genetic people, and genetic counseling was done nicely, and now she's having a baby with them. So,
Excellent. That is so nice.
with proper counseling and which test has to be done and how to interpret the test, that is very, very important. So we should not do in the ego that we should do all the things ourselves. We should take the help of the fetal medicine people, genetic people, and pediatrician also.
As
Whenever
a team. Yeah.
as a team, it should be multidisciplinary approach.
Ma'am,
Thank
is
you.
there any
Thank you so
test like ultrasound guided biopsy of that fetal muscle to diagnose that dystrophin gene? Is there any test? Is it available? That is a ultrasound guided biopsy of the fetal muscle to diagnose that gene dystrophin in DMD.
In DMD, there is a dystrophin is actually one of the largest genes.
Yeah.
And when you have to look for the mutations, there are multiple types of mutations. So the best thing would be to do the index case. You do a gene sequencing of the index case and find out what mutations are there. And then you look for the same mutations in the otherwise, if you don't have a confirmed diagnosis, then you have to go for a gene.
Okay.
Excellent talk, Chinmay. You
Thank you, ma'am.
take any talk, you talk on any topic, you make it very easy.
Very simple.
It's understandable for everyone. So
Thank
that
you,
is the
ma'am.
beauty of your talks that I always enjoy listening
It's
to.
always a pleasure to listen to, ma'am. It's always.
Dr. Chinmay,
so much.
this is one of the finest talks I have heard, and every talk is like this, the finest and the finest. So excellent,
Very crisp.
just fantastic. Such a complex topic, simplified, and everybody could, like you rightly said, that you will speak in such a way that because when I spoke with Dr. Chinmay, I told her that this is for obstetricians, not for fetal medicine. No, she said, no, this will be for everybody. And you saw to it that each and every one of us understood. So thank you so very much.
And Chinmay, you won't believe, last time I was in ASHRAE, we were only talking about genetics for the fetus. And then I heard this gentleman, I know his name, just slipping out of my mind, who did this mitochondrial diseases, three parent baby, where he took mitochondria from the donor egg and the nuclei of both mother and father, and that is how created the embryo. And very popularly did it in China because he was not getting ethical permissions in the US. And in fact, he showed the pictures of the first babies that the couple had with mitochondrial disorders, and then the healthy child. So that was like an eye opener. By then, he had already had
Genetics
9
is amazing.
out of mitochondrial transfer. So yeah. So genetics is amazing. It is indeed
Difficult
amazing.
also. Amazing as well as difficult.
Very difficult,
Yes.
right?
We'll move to the next session.
Yes.
Yes, ma'am.
Okay, ma'am.
Thank you for that wonderful talk on genetics, ma'am. It was really, the examples you gave, they were really brilliant. The way you can think like that and make us all understand. Thank you so much. So let's move to the last talk for the session today, which is going to be by Meenu ma'am again. It is on case study on intrapartum care for safe motherhood.
So
Over
I'll
to
be
you.
just reading out this case study, which has been very nicely given to me, shared with me by BSV people. So I'll be just reading it out. This is a case study of a lady. She is 28-year-old, para 1, gravida 2. She came at 33 weeks of gestation with preterm labor. She had
Your
regular...
slides, we can't see, ma'am.
Okay. You can't see, so stop share. Right.
No, it was visible just now.
Now, one moment. Now is it visible?
Not now, ma'am. Previously it was visible.
I couldn't
Okay.
see. Maybe it's.
All right. Okay. I will.
Yes, yes.
All right. So she's 28-year-old, G2P1, 33 weeks of gestation, and she came with preterm labor, symptoms of preterm labor, regular painful uterine contractions every 10 minutes for 1 hour. No anything in medical history, and no history of drug allergies. She has a previous history of a full-term vaginal delivery without any complications. Now, on examination, vitals were normal. Baseline fetal heart rate 140 per minute, and she had mild uterine contractions 8 to 10 minutes, lasting for about 30 seconds. PV examination, Bishop's was 6, cervix was 2 centimeters dilated because she already has had a previous normal vaginal delivery with 50% effacement. Given the clinical presentation consistent with preterm labor, so they formulated a management plan so that they can give steroids for the fetal lung maturity, arrest the uterine contractions, and prolong the pregnancy. So they discussed everything with the patient and her relatives, and then they decided to administer Velethamate bromide intramuscularly. So she received 8 milligram of Velethamate bromide by intramuscular injection. She tolerated the medication well. No adverse effects were noted. Continuous fetal monitoring was done to look for any signs of fetal distress. What was the outcome? After the administration of Velethamate bromide, her uterine contractions subsided. She reported a significant reduction in discomfort. Serial fetal monitoring demonstrated stable baseline fetal heart rate patterns, and she remained in the hospital for observation and to receive a course of antenatal steroids. Excuse me. In follow-up, she was monitored for 48 hours to ensure adequate tocolysis and fetal well-being. Cervical examination did not show any progressive change in cervical dilatation. She received counseling. If she has any signs and symptoms of preterm labor, then she can come back, and she was discharged. So this was a particular case study that on Velethamate bromide. Thank you very much. Yeah. Ali, I think you must be having more experience with this molecule. So maybe you can talk about it, or we can discuss it with others who have any experience with this molecule.
Yeah, very interesting case study. So anybody would like to add any comments? So I think we have come to the end of the webinar, and it is
just one.
Velethamate bromide is epidocin, na? It's epidocin, na?
Yes, that's right.
Bromide is epidocin.
Yes, yes.
We are using since a long epidocin. But for when patient goes in labor, then we are using epidocin a lot.
But this is for preterm labor. That's why.
Yeah, but for preterm labor, we have never used.
That is also for dilatation for.
Yeah.
So this is a single case study that you have presented, right, Dr. Meena? This is a case study that you have presented.
Dr. Priyanka, can you just say a few words about it, please?
Because as per the guidelines, so many guidelines, RCOG, NICA, COG, all guidelines, this has not been implemented by supported by any of the guidelines. So this is a very interesting case study, and we hope to see many more work being done and publications regarding it. Anybody would like to add regarding this? Mr. Prasad, anybody from BSV side?
Yeah, ma'am. We have Dr. Priyanka. 1 second, ma'am.
Because this is the basic that we get, patient coming in preterm labor. All whatever sometimes we talk is all also routine, but not so routine. This is a very, very routine thing, and we should know how it helps in a preterm labor. Dr. Priyanka, can you talk about it for a minute before we close?
Hello.
Yeah, Doctor, you're audible. Dr. Priyanka, you're audible.
Yeah.
Yeah, can you explain this particular case study? This valethamide bromide is epidosine, right?
Yes.
Okay, and you have used it for preterm labor.
Oh, yeah, in the certain case, yes.
Do you have any references, any studies to back up this use?
Ma'am, actually, one of the doctors had given me a sample as such, but I can give you the studies, but there are very, very, very few studies on this. So it is just one of a very different case where, epidosine was used. Usually it is used to shorten the first term of labor, but this was a case which I found that maybe it can be used.
So is there a possibility that it was a false labor pain and patient just became all right on her own?
Not really. I mean, that's not what I was conveyed.
So, Dr. Priyanka, can we say that this is a singular case study, and
Yes.
take-home message here is not at all that epidosine should be used for threatened preterm labor, because there are certain guidelines which we follow for managing threatened preterm labor. So, this is an interesting case study, but the take-home message for our delegates is we will wait for more evidence regarding this. Is that right?
Yes, Dr. Vaishali. So the point is that we usually have this typical case studies when it comes to valethamide bromide. So this was something that I found quite different. So I just wanted to get an opinion. I mean, is this possible, or do we need more research, or
No, it is not recommended. It's not as per guidelines, and it is very initial stage, and more work will be done. So I think let's give a clear message here to all the viewers that this is not what we recommend right now. It needs more evaluation, more evidence. I think Dr. Sangeeta also agrees, and
Yes.
Madam also agrees.
Because this is just a single case, how we can use in the threatened preterm. Yes, if she's in already an advanced preterm, we can give epidosine just like in the term. That's all.
Yeah. All right. So, Dr. Meenu, can we close the webinar?
Sure, please.
And I propose the vote of thanks. So, this has been a very interesting webinar, and it is my pleasurable duty to propose vote of thanks. And I would like to thank our chief guest, Dr. Alpesh Gandhi, Dr. Ragini Agarwal, Dr. Asha Bakshi, speakers, Dr. Meenu Agarwal, Dr. Chinmay Ratta, our chairpersons, Dr. Surjit Kaur, Dr. Sukriti Bansal, Dr. Archana Berry, Dr. Sangeeta Pehwa, and Dr. Charu Bapaye, Pune Obstetric Gynec Society, and our very young Dr. Madhura, who has been conducting the program, and BSV for their support, Mr. Prasad, especially for being with us throughout. And a special thank you to Amritsar OBGYN Society and Jalandhar OBGYN Society. And thank you to everyone. And most important, thank you to all the delegates who have logged in today and who have made this webinar a success. Thank you, all of you, for being with us today. Thank you.
Thank you so much, Dr. Vaishali. Thank you so much.
Thank you, everyone. Thank you, Vaishali, Charu, Madhura. Thank you, Amritsar and Jalandhar OBGYN Society. Thank you, Dr. Sangeeta, for all your valuable inputs.
Thank you so much.
Helpful, yes. And of course, Dr. Chinmay for a very good talk. BSV people, our chief guests of honor. And Dr. Priyanka Joshi for giving this case report, and we could at least discuss and debate about this particular case. And all the doctors, I think I can see some Dr. Preeti Dev, Dr. Sonia Rana, and Dr. Archana. So all of them also I can see over here. I think they have logged in, but they have kept their videos switched off. So these are the faculty, some of the faculty who have logged in. So thank you very much. And we look forward. Next Tuesday, we don't have the cutting edge webinar because I keep getting messages, when is your next cutting edge, next cutting edge. So we have it, today is
12th March.
Next to next week now.
Yeah, we have on
So
12th.
next week we have the transgender program. So next to next week we will be having the cutting edge webinar. So Chinmay, we have a social cum scientific program by POGS.
Dr. Ragini is here. Meenu, Dr. Ragini is here.
Hello, Dr. Ragini ma'am.
Yeah, I just landed to Mumbai airport. I think I said hello to all of you. I think program to khatam ho raha hoga na?
Yeah, we are just saying goodbye, but we are so happy to have you here.
आप नहीं आए थे तो खत्म नहीं किया था मैम, अब खत्म करेंगे.
Thank you for invitation. I just wish you all Meenu best for your future.
From you.
Thank you.
Yeah, thank you for joining, ma'am.
Okay, bye.
Let us have a few words from you before we close, Dr. Ragini ma'am.
few words तो देखो सिर्फ यही कहना है कि हम लोग इतने वेबिनार कर रहे हैं. I think every webinar we should come out a small gist of it like a booklet, because it is so much of the knowledge, condensed knowledge. And my suggestion to you, Meenu, it will be very good for you if you make a gist of your every webinar and send to all the members of the FOXY.
That's a good suggestion. Thank you so much. Very good suggestion. Yes. Thank you.
Okay.
Thank you.
Yeah.
Thank you. Dr. Chinmay,
Okay.
can I have from you
Bye.
just 2-3 small key points so I can just post them?
Definitely, ma'am. I'll make a summary and send you. Yes.
Yeah, I don't need a summary, just key points, just take home. Two lines. Thank you.
Definitely.
Thank you, Dr. Ma'am. Very, very good suggestion. I loved it. Yes, thank you.
Okay. Bye.
Bye.
अब टैक्सी पकड़ूं जाऊं? वेट कर रही हो, बुला रहा है बार-बार. Okay. Bye. All the best. Bye.
Thank you.
Okay. Bye.
Recording stopped.
Sangeeta, we'll keep in touch.
Thank you. Definitely, Meenu.
Yeah, nice meeting you, Dr.
Your
Singh.
presentation was excellent, and Vaishali, you are too good.